Well, tēnā koutou katoa. Very pleased to welcome you to this Department of Public Health Friday seminar. And of course, it's wonderful to be in a COVID-free New Zealand. And so today, Nick Wilson and myself are going to summarise why we think the elimination strategy is the best choice for New Zealand. We didn't think we needed to put a question mark in there. And so I'm going to speak for a few minutes and then Nick, and hopefully there'll be some time for questions. And I just want to acknowledge particularly Amanda Klausvig for her huge contribution to this work. So this is, some of you may have seen this, one of the best outcomes of the flag debate was a wealth of interesting graphics. So today we're going to talk about some of the strategic choices that New Zealand faced, this big one between mitigation and elimination, the components of the strategy, its impact, uncertainties, and I guess what we can learn from this and where we go to from here. So when you're confronted by any public health challenge, there's a whole checklist of considerations, and this is really core public health issues, looking at impact, particularly case fatality risk. There's a thing, the infection fatality risk, which is often unknown, and that is what proportion of people actually are infected and die, as opposed to those that are known cases, and that's often unknown initially. Inequalities, fortunately, is a major consideration in New Zealand. And some of the things feeding into this are the transmissibility of the pathogen, and particularly its controllability. What can you do about it? The certainty of information is always limited by definition. Emerging diseases, you don't know everything about them. And this is where you start to interestingly get involved in our science capacity, options, counterfactuals, experience, and even dogma. You know, some of us have ideas where we stick to. And then the feasibility of the response, the capacity of the system, and economics, which are often very hard to measure in a disaster situation. So we had, like many countries, did modelling of a range of scenarios, and I really congratulate Nick for taking the lead with this. And this fed into the decision-making made in New Zealand. And in the end, we were heading towards a most plausible estimate of a poorly controlled pandemic in New Zealand with some constraints. Obviously, people change their behaviour when confronted by a threat of maybe around 13,000 fatalities, given a reasonably likely scenario. And this is clearly not just a bad influenza season. This is 25 influenza seasons, all stacked on top of each other. And that's ignoring a lot of the other secondary consequences that occur if a health system is completely overwhelmed. A lot of other things don't happen. And even now, we're seeing some of the consequences of that without the pandemic, just what the health system did in response. The other, I guess, lesson from history is that pandemics, like endemic disease, magnify inequality. And even though this is the mortality for Maori and European New Zealanders over a century, and you can see we did a bit better by 2009, but there was still marked ethnic inequalities, and we would have certainly seen that with the pandemic in New Zealand. So for all of us looking at this, there were some light bulb moments when you suddenly thought, actually what I was thinking, I have to revise my views. I think the first one was really at the end of January, seeing this, and you won't be able to read that, but it was a really nice piece in the Lancet at the end of January saying, this is clearly going to be a global pandemic, the way it was spreading out of China. The second one was at the end of February, a month later, this report of a joint mission to China had very credible scientists on it and said, actually, it's not a reporting artifact from China. China has really done the unthinkable. It stopped a respiratory pandemic in full flight. So there's nothing biologically impossible to stop this disease. So I guess that was the other huge realization for all of us looking at this. And then by mid-March, the other light bulb moment really was New Zealand had no hope of containing this with basic measures, just managing borders and just doing contact tracing. Unfortunately, the entire country needed to be put into home quarantine for several weeks to stamp out the pandemic. And that was obviously a far more contentious viewpoint because of all of the consequences. So we were going into this with a mitigation approach. It's built into the pandemic influenza plan that we have, and this is the plan that every country in the world has been working on for 20 years, gradually refining it with guidance from the World Health Organization. And this has flattened the curve. And it's got these steps that people in the field are very familiar with, about keeping it out for a while, stamping it out for a little while, managing it so it doesn't overwhelm your health system. So that was absolutely the plan at that point in time. So the alternative elimination, this has got a long history in infectious disease epidemiology of eliminating diseases at a country or regional level. Say polio, we're trying with measles and rubella. And eradication is the idea of global elimination, if you like. And that's really only been achieved, of course, for smallpox, but it has been achieved for some animal diseases. So elimination is very different. You're trying to stop the curve. There isn't any flattening of the curve. And New Zealand switched very dramatically to this approach on the 23rd of March, when the Prime Minister announced we're going straight to level 4 as fast as we possibly can. And at that point, there were 100 cases in New Zealand and no fatalities. So her phrase about going fast, going hard, that was what we did. And so the elimination strategy really just has 3 elements. It's you're excluding cases at the border, you're doing good case and outbreak management with testing, contact tracing, isolation, quarantine, and then you're dampening down transmission. And really, there are very, very limited ways you can do that. In some ways, it's quite accurate. We're using medieval tools from the pre-antimicrobial era and the pre-vaccine era. And some of these concepts like quarantine, of course, date from centuries ago. So we all lived through this, so we know a lot of this very well. And some of these key dates are probably etched on our collective consciousness now. But border management was something near closure. We never totally closed our borders, although there were 2 remarkable days when no one came or left New Zealand, which really had people looking back through ancient records to see when had that ever occurred before. So these are obviously very unusual times. And we're also familiar now because, of course, the debate has become very intense over how you manage borders. And some of these ideas about supervision and quarantine. And you probably know we've got the terms around the wrong way. Quarantine is what you do with people who are exposed but not ill. Isolation is what you do with sick people. But anyway, it seems very hard to change. Epidemiologists squirm when we hear these words, but anyway, and there's a whole lot of key dates here when we gradually increased controls, and there were some dramatic moments when we said basically entries closed except for New Zealand citizens and a very small number of other exceptions, and then moving to this more supervised approach. And Luke, I don't know if he's here, has done an amazing job of documenting some moments around Wellington and New Zealand during this period, a really good photographic and video record. So the other part was case and contact management. And again, we're going from a very low base here of doing this, and really quite a small workforce and systems. And this was really increased very dramatically over this period. And this is one of the reasons for having the lockdown, was to enable New Zealand to get all these capabilities going. There's still unfinished business here in terms of the potential for digital assistance with this. And there were a lot of key dates here when testing was introduced. Our colleagues in the laboratory sector did amazing things with, again, building up this capacity from a very low base. And a whole lot of people from different areas repurpose their equipment for this. And so we've seen these amazing days, and I think the most recent day was over 10,000 tests, and it's not on this graph, but really a phenomenal level of testing in New Zealand. So this third component, after the borders, case management, is dampening down transmission. And it comes down to this number that sort of takes on almost a magical quality, the reproduction number, that people actually start talking about this actively. So that, of course, did make the epidemiologists very happy. And again, this number is not, it's not a fixed number. It depends on populations and how they behave. And after it's modified, it moves into this effective reproduction number. But you can't, one thing you would like to modify is the duration of infection. Unfortunately, we can't do that. We don't have antivirals, so you're stuck with that. So all you can do is dampen down transmissibility, and that's transmission per contact, and the contact rate. How many contacts do you have in a period of time? And this is where a whole lot of things feed into these qualities. And of course, staying at home dampens down certainly the contacts you have, but transmissibility may not change. So that's where things like hand hygiene, face masks, and so on come in. So we've all seen this. You obviously can't read that. I think it was delivered to every home in New Zealand, the 4-level framework. It was a really brilliant piece of risk communication. You can argue about some of the details at each of those levels, but really I think it achieved the job very effectively. You can also argue about the criteria for moving between these levels. Obviously that was very contentious how you did that. So reducing transmission per contact, this is physical distancing, staying at home is sick. We're very familiar with all of these things. And of course, in many countries now, there's huge focus on wearing masks. And interestingly, it's not part of our cultural tradition, and we didn't become a mask-wearing society. But the evidence is so compelling now that this is actually can substitute for a lockdown in terms of suppressing transmission. So hand washing was mentioned a great deal, and again, physical distancing, and we're all familiar with the closure of places where people meet, staying in your bubble. Again, a nice piece of risk communication, and these dates when we move between different levels. So this is Wellington and rush hour. So I don't know, those of you who went out walking and cycling in this time, I guess many of us have amazing, quite positive memories from that remarkable period in our lives that I think will never be repeated, probably. But we are, of course, fortunate that many of us could work from home, and for some New Zealanders, this was a terrible time because, of course, they're losing their jobs and their livelihoods. So it's a mixed experience. And a lot of interesting adaptations to physical distancing. This is at level 3. And this was the flyer delivered to all New Zealand households. And again, that's a very busy slide, but this is like the Ministry of Health's composite of all the things done. And I think it just shows that there were a lot of steps along the way, but the really dramatic ones were this very rapid move to level 4 and then quite a sustained period in level 3. And of course, that coincided, fortunately, with then a huge decline in disease incidence. And quite clearly, New Zealand was just at that point of switching from basically imported cases to local transmission. And so we were, we really couldn't have left this very much longer, or we would have had a sustained epidemic. And we were already obviously on the beginning of that exponential rise. So this is modeling done by our colleagues at the University of Auckland using the slope of this curve to estimate reproduction number. And you can see we went from a effective reproduction number of about 2 prior to the lockdown to under 0.5. So that, as you know, is enough to make these lines of transmission gradually extinguish themselves. And you can have transmission within a big household bubble, of course, for a few weeks, as the virus might move from one person to another. So time actually is on your side if you're trying to extinguish a pandemic at this time. So this is another completely different method, and so it's a very busy slide, but this is using phylogenetic methods based on sequencing 200 or so isolates of the or viral specimens and looking at how they change. And that is it's very clever work being done by Alexei Drummond and others at Auckland University, showing how, again, the same decline in the reproduction number from over 2 to under 0.5 over this period. And they've also looked at, used data from Australia and Iceland and seen similar declines in the reproduction number. So how do you know when you've reached elimination? This was, has been debated quite a bit, but there's 3 parts to, we put forward a conceptual definition that basically absence of infection for a certain period gives you a high confidence that you've achieved elimination in the presence of a high-performing surveillance system and with some defined exclusions. So people sitting safely in quarantine at the borders obviously don't contribute to your definition. So this is saying, what was the choice faced by nations at this time? And this is saying that you've got the mitigation approach, which is the if you like, the default option. And this says the pandemic washes over you, but you suppress the curve to minimize harm. This approach turned out to be very unsuited to this virus. And so partly because the pandemic wave is very prolonged. So most countries that have intact health systems quickly move to a suppression approach. But that means that you are stuck with this pandemic, and you may be going in and out of lockdown for months to years unless there's some intervention. So I think it's probably only Sweden for a period that's stuck with the mitigation approach. And unfortunately, much of the world has no really substantive strategy, almost looking like the US, unfortunately. And you do wind up here with, you are really affected very much by the behavior of the pandemic interacting with your population. So I think looking at the alternatives, the counterfactuals, the other options up here look very appealing. And obviously many island states in the Pacific, they weren't waiting around for WHO to decide it was okay to shut your borders. They just pulled up the drawbridge very swiftly and very successfully. So Samoa, Tonga, and a number of other Pacific islands and some Caribbean islands, and excluded the virus. Then there was the elimination approach. Once you had established transmission, was the view that you could actually stamp it out fully. And that's, again, what mainland China showed. Taiwan is probably the best example of doing this really effectively. And so we're in an expanding group of countries that have successfully eliminated transmission. And so hopefully then you return to this carefully managed new normal, a term I don't particularly like because I think we should do something different, better. But, and that's where we are now, and this obviously requires a focus on your borders. And all of these ultimately require an exit strategy that may depend on a very effective vaccine, plus or minus therapeutics, and one may come before the other. So, are you actually, Nick, do you want to take over at this point? Yeah.
So carrying on, this is an example of the different mortality burdens of under those different strategies. And you see New Zealand, if you look at the far column of deaths per million, it's pretty similar to Australia and Singapore, but some of these Asian countries that learnt a lot from SARS actually have done even better than New Zealand. Hong Kong, Taiwan, China and Vietnam, and you know, island nations that largely followed the exclusion strategy. But really dramatically different for these countries following suppression, these European and North American countries, hundreds of times the per capita mortality rate, particularly Belgium, but yeah, all these other countries, and really standing out is New York State with many hundreds of times the mortality burden of New Zealand. And in terms of mitigation, which Michael mentioned, is the strategy Sweden started off with. You know, they have not done well at all, very similar to other European countries. And in fact, their economy has suffered similarly to countries, other Scandinavian countries, particularly when comparisons are made with Denmark and Norway and Finland. And then, yes, unfortunately, we're just seeing this tragic situation in places like Brazil, where the leadership has actually failed to define any strategy at all, and it's just a chaotic situation. So how do we maintain COVID-19 elimination? So the threats are ongoing, you know, failures of border management, and hopefully now the New Zealand government is putting even more resources into improving their border management. There's concern with when we look at other seasonal coronaviruses, there's 4 of them that cause cold-like symptoms every year. They all have a marked winter peak, and so if transmission was re-established in the community in New Zealand, we could expect to see increased transmissibility in winter. And, you know, we've just suddenly jumped from alert level 2 with a limit of 100 people in social gatherings, up to unlimited 40,000 people in stadiums a few weeks ago. So we do really need to keep an eye with good surveillance to make sure those type of events are not hazardous. In terms of wider health threats, there is the indirect health effects of the response, the lockdown, the reorientation of the health systems. There will have been people whose cancer treatments have been delayed, people with heart attacks maybe not getting a stent as quickly as they might otherwise get it, delays in screening programs and so on. And these adverse indirect health events have not yet fully been assessed in New Zealand, but we know from other countries that they can be important. There's the issue of economic hardship and increasing inequalities, socioeconomic and ethnic inequalities, and particularly the impacts arising from the downturn of international tourism. So these economic effects will be often very concentrated in places like, you know, Rotorua and Queenstown and places that relied a lot on international tourism. And then there's the issue of the multiple global health consequences we're seeing, where, you know, there's going to be an increase in poverty and malnutrition. Even diseases like tuberculosis in places like India do seem to be spreading more easily because people have been confined in the lockdown situation. There's been big disruptions to screening programs, immunization programs. And so the global health consequences are going to be very severe, not just from COVID, but all these other consequences as well. So we definitely need to maintain careful border management, and a key aspect, and I was talking on to the media about this today because we published an editorial in the New Zealand Medical Journal led by Amanda on the importance of mass masking, particularly in the border situation, but to build masking into our alert level. So if we do have to move back to alert level 2, we can have mask use on buses and trains and shops and workplaces so that we can avoid the risk of a further lockdown situation. We need to enhance our contact tracing with digital tools. There's work being done on a so-called COVID card, a smart card that's Bluetooth enabled that would help with contact tracing, but that's still possibly weeks to months away. And we need, I think, also to learn from places like South Korea, which had emergency laws that allowed even telecoms data to help with contact tracing. Obviously, there's privacy concerns, but maybe there's ways to deal with those privacy concerns if it's going to avoid another lockdown situation if we have a border control failure. And we need to rapidly review where we've got to. And, you know, we've put out calls for a commission of inquiry to understand what's happening and to get some rapid review work done, so to guide the next 6 months. But we do need a larger review that really learns all the lessons from this major event. I mean, this is one of the biggest events to hit New Zealand since probably World War II. So it's absolutely imperative that we pull together all the lessons from it. There's still a lot of uncertainties with this disease, huge uncertainties about if a vaccine will be developed and when that might be, the potential role of antivirals. There's been small improvements in treatment, but no really major ones. We know very little about the duration of any immunity for those people who've been infected. So we don't know if it's going to be like other seasonal coronaviruses where people get infected every winter with coronaviruses with cold-like symptoms. We still need to learn more about the optimal mix of strategies, and particularly in New Zealand, that filling that gap around how to make use of face masks and to improve contact tracing. Managing inbound travel, there's huge pressures of with returning New Zealanders. We've got to figure out ways to better manage that and to sort through the issues of should we have travel bubbles with other COVID-19 free nations. I mean, possibly Taiwan is the most feasible nation to be in a travel bubble with, or very specific nations that have never had COVID-19. I would have thought they're all higher priority than Australia, where the situation is still far from coming under control. And as we've discussed, there's these big social and economic consequences and how best to respond to those. So just to summarise the strengths and weaknesses of New Zealand's response as we see them, we thought there was a good response in terms of epidemiologists and public health people feeding into the system. There was really strong leadership from the Prime Minister and the Director General that helped with decisive action. New Zealand's only had chief science advisors for a few years, and they were important players. And generally, when you compare New Zealand with places like the United States, you have very high levels of public trust in official advice and engagement. And I've heard people say this may reflect New Zealand's strong team sports playing culture. We know how to follow rules in team sports, and it may help us in these sort of situations. But the weaknesses, we did not have enough work done on our pandemic planning documents. Our pandemic plans were focused on pandemic influenza and not on other emerging diseases. And even though we had the global experience with SARS in 2003, another coronavirus, our public health system has been run down in many ways. We have, last year we had measles outbreaks. A few years ago, we had the disaster in Havelock North with the water supply. We do honestly have an eroded, fragmented and underfunded public health infrastructure. And there's a lot of uncertainties with the structure of the health system going forward. And as we've discussed, there's been a lot of resistance to innovative policies like using masks. And we've had various failures at the border where improved management was definitely needed. So really to highlight the main points and key lessons. So we really need effective risk management in these type of situations, and strategic decision making is important. And New Zealand adopted the right strategic approach with elimination. We really need effective science and leadership, and New Zealand had some particularly good leadership at this time. We need to strengthen public health infrastructure for this. I mean, this crisis is going to continue in various ways, but we also need to be prepared for other future crises, particularly disasters arising from climate change, for example. We need to strengthen and reform global health agencies. WHO has done a great job in many ways, but it's also made mistakes, and but it needs to be dramatically better funded to deal with these sort of crises in the future. And this whole event is an opportunity for a broad reset and an increased focus on managing our major global health threats. So there's definitely opportunities there. It's been the work we've done is been in collaboration with many other colleagues and successfully led by Michael. There's HRC funding for the co-search program of collaborative research with Auckland and Massey, ESR and Kokiri Marae. And then just to finalise this great Winnie the Pooh situation of with Piglet asking, but how will we know if our pandemic guidelines work, asked Piglet. The world will think we overreacted, said Pooh. And that's a real public health story that the triumph is that nothing happened, and we avoided all these thousands of deaths from COVID-19. So now I think Michael and I are very happy to answer questions.
Thanks. I'm Jude from the Public Health Department. Thank you for a great talk and for the work you've done to make sure that nothing much happened here. My question is around testing of sewage to detect the virus. I understand that's been happening internationally. Can you tell us a bit about that, and is there work happening in that space in New Zealand?
Yeah, ESR has got funding to do that, and they also archive some specimens from when there might have been circulating virus, so they can use that to calibrate the testing methods. But it is proving useful overseas, and it could be a backstop measure. But you know, the number one priority is what we're doing now, which is testing a whole lot of asymptomatic people who are in those settings, so that sentinel testing, as well as obviously people with symptoms.
But actually, carrying on from that point, it could actually be done in quarantine centres. You could be testing the sewage from the quarantine facility every half a day to actually understand what's happening.
Thanks very much. Neville Pearson from the Department of Public Health. I was interested in the comment that the cases in the border don't count, and as an epidemiologist, I'd largely agree with that. So I was wondering, have you looked at the R numbers in the curve when you exclude those who were kept in the hotels and the managed facilities?
No, we haven't done that, and in fact, I don't think our colleagues in Auckland actually were very good at doing that either. You know, some of the data from the Ministry of Health was not very clear on these sort of points, so it actually was quite hard to do. But as a general thing, there is terrible confusion out in the public about the difference between active cases in quarantine and isolation and community transmission. You know, if you look at the international media, you'd think we were like a place with uncontrolled transmission. And again, it comes back to unfortunate communication by the ministry on their website, where there's no differentiation between people, active cases in isolation, and the fact that we've got no community transmission. Ashley Bloomfield every day should be saying, we have no evidence of community transmission for X days, and all our active cases are under quarantine. And so we expect to continue with a COVID-19 free situation. But unfortunately, that message is not out there, and journalists are confused, the international media is confused, but we're actually in a very good situation where the probability of community transmission is, I would have thought, just a tiny fraction of 1%.
Yeah, I should just add, part of this is actually caused by the way WHO collects data. Was in most countries, all the action really is local transmission. They would barely distinguish imported cases because they're making virtually no contribution. And they just want that daily total of cases diagnosed in your country. So we are following the standard international convention. It's just that it's very misleading for countries that have achieved elimination. Hi, Len.
Hi, Len Coulter, statistician. If Edward Deming, you know, the grandfather of continuous improvement, were here, he would say, we're now sort of in the eye of a storm. We've had this massive experience. We didn't know a lot about it at the start. Yeah. We've now got a huge amount of knowledge. Nick made the point, there should be a review. A drover's dog would tell you that. Now, if ministers are too scared to do it, what do you think that people who have played a massive leadership role like you two have, be tremendously important for New Zealand? How do you see such a review happening in the absence of political and departmental will? We must have it, surely. I mean, unless we're going to throw away the basic tenets of continuous improvement.
Yeah, totally agree with you, Len, not surprisingly. Well, this is a $50 billion public health intervention. So it should have a proportionate level of scrutiny, evaluation, review. I don't know. It used to be,
10%.
yeah. Well, they used to have 1%. It seemed to be some strange convention historically. But it's obviously time to do it. And we can't wait to the end of the pandemic because that may be years away. And so now we have a moment of comparative calm to do this. And so I think, why not do it now? Whether pre-election is the best time to do these things, I'm not sure. But I think we do need this dedicated agency. And in our department, we worked very hard on putting in a big submission to the Health and Disability System Review last year. And not one element of that came through in the final report, which was focused on healthcare systems. And it's considering the composition of the people on the panel and Heather Simpson, her interests. And it does need attention, and it's a massive area. So we're not begrudging that. It's just that we need another kind of rapid review to fix up public health. I don't know if there's anyone in the room who's read through that report and thinks it did justice to public health. Anyone game to put up their hands? Who thinks it did not really reflect public health needs? Oh, that's good.
We have a question from the Zoom participants, which is, given billions spent on COVID-19 elimination strategy, is it possible that in 10 years' time, the Swedish strategy might prove more cost-effective at a population level in terms of years of life lost?
Nick, Nick's more than
I think there is a small chance, but from what we've seen, the herd immunity build-up in Sweden is at a very slow rate. I think it's, the last time I saw, only 7% herd immunity. So Sweden might be putting up with ongoing suppression, mitigation for maybe another 2 years before the pandemic basically stops in their country. And even then, if they have pockets, if they've done a good job of protecting the elderly, which they haven't, but if there's groups of elderly who are all non-immune, it just needs a visitor from another part of the world and you'll get an outbreak in a aged residential care facility and so on. So yeah, I think Sweden has made quite a big mistake. Even though I sort of quite like the way they make decisions, it's just technocrats and the politicians. We're not involved at all, but in this case, I think it's been a mistake. They really did think this was like pandemic influenza, maybe a slightly worse strain, but this is 10 times as bad as seasonal influenza. So I think that was a misjudgment, and we still don't know if herd immunity will build quickly, and we don't know how long it's going to take to get a vaccine, and it could be quite a long time. So I think the general feeling now is that Sweden made a big mistake.
Do we have any more questions? Yep, 1 second.
I found it personally very interesting was that Johan Giesecke, who was one of the big proponents of the Swedish model, actually did a sabbatical with him 5 years ago. So we had that slightly surreal experience of both being on British television debating the relative merits of our approaches. And so that was one of many strange moments where suddenly you feel very connected with people all across the globe, even though you might have different opinions about what to do about a problem.
My question was about the political dimension and thinking about the list of threats to our elimination strategy and the extent to which, you know, that political dimension is a threat. And I'm just wondering, given the importance of the political leadership, and you can see that in the mortality differential across the world, even in the countries that scored so highly in their pandemic planning, do we have a political consensus on elimination, and what is the extent of that political risk?
I might start with,
yes,
yeah, I think there was good political consensus in the early period, but then as we got to level 2, politicians were trying to distinguish themselves by racing out of the alert level system and being business friendly and so on. So I think it was a bit risky then. We, you know, as I said, we just jumped from limits of 100 people to 40,000 people in the same gathering. It seemed epidemiologically somewhat reckless, really, and that were political imperatives were driving all that. You know, the Ministry of Health was advising a much longer time at alert level 2, and I think any rational analysis, given alert level 2 wasn't doing much harm to business, it was hitting a bit the hospitality sector, but other businesses were basically back in action. So the economic cost of level 2 was quite low, and yeah, I think it was political imperatives driving things. And this highlights again, you know, we should have had more technical advice on when to sensibly move from alert level to alert level, rather than it just being taken over by a political process, which was unfortunate.
Last question.
Hi, Phoebe from Massey University. I was just thinking about the recent outbreak in Beijing, and how rapidly something like that can happen. And given that testing, I think, in New Zealand is currently prioritised towards suspect cases, how quickly could that kind of thing happen here? And is that some of your thinking behind trying to promote the masks? Would that help? Yeah. And how many, how big is that risk?
Yeah, I think that's very much a risk for New Zealand. Hopefully it's a low risk if we keep managing our borders properly, because we've almost certainly have no virus circulating in New Zealand. I think it's very challenging remember, China is protecting 1.4 billion people with very few outbreaks, so they are doing remarkably well. So I think the evidence is on the side of the elimination still, but there are these threats, and so most countries have had setbacks. So South Korea, Singapore has had really quite a severe one, and obviously China will keep having these because it's got such a vast border and to manage. So that is a threat for New Zealand, particularly in wintertime. I think the testing approach is geared towards picking up those outbreaks, but I think modelling work I know Nick has led says that it might take a few generations of transmission before you become aware of an outbreak, and that's where the contact tracing comes in to basically manage those cases. And I think that system is now pretty robust and geared up for big outbreaks. But if we want to have all these other defences going up a level, having masks available, I mean, we just got the line that we think every New Zealander should have a face mask and know how to use it if necessary. So I actually think New Zealand's in a pretty good position to manage those outbreaks and detect them and manage them if they occur. But it is that is the big concern going ahead, that event.
Combined with New Zealanders' natural complacency, and she'll be right, this has been quite an eye-opener to me that, complacency does set in. We haven't dealt as a country with big emergencies like this very often. So I think we all need to be alert that, this is time for continuous improvement, as Len said, and to learn the lessons from other countries. I mean, we just have to learn more about why Taiwan is so successful, why they've had no community transmission for 60 days. They're much closer to China. They had cases much earlier, and they had no lockdown. So, there's our countries that have done better than New Zealand, and we really need to learn from them. We just, New Zealand traditionally looks to Britain and Europe and North America. We actually have to say that, we've got to learn from Asia. They learned from SARS. We learned nothing from SARS. We have to, look more widely than just our Anglophone heritage, which has not helped us in this case.
Yeah, just to add to that, I mean, despite Taiwan's amazing success, they just passed a law requiring people to wear face masks in public transport. So they're not sitting around waiting for the virus, they're going to actively manage it. I think there was a statement by the editor of The Lancet that the whole world had adopted this approach of complacent exceptionalism in the West. And I think we have to move away from that and just be far more proactive risk managers. And I think a core part of that will need to be a dedicated national public health agency to take on these responsibilities. because we know the lesson of history in New Zealand is that these functions, if they're left in a policy-orientated organisation, get systematically eroded over time. It's just the way government agencies behave. We've all seen that. I think it's absolutely time for this agency. I don't know if everyone in the room agrees or not, but this is something we hope we will get some collective movement on across New Zealand. Thank you.
And finally, just to remind people that Taiwan has a deputy prime minister who's an epidemiologist, and I think that's something we should definitely learn from.
So you're looking for a new job then?
Well, maybe Aisha Vera is moving into that role.
Thank you very much on behalf of everybody for coming and giving this presentation, and thank you everybody for attending. Next week we have Hera talking about gun control, but thank you for all your questions.